Ophthalmic Epidemiology and Prevention of Blindness, Meeting Global Eye Health Needs. And thanks to the NAG for sharing with me. So we have, actually I requested for a video from our president, Dr. Neeru Gupta. She has sent it. Dr. Amol, can we play that? So Dr. Neeru Gupta is our president and myself as treasurer, and EO is the CEO, and we have Dr. Ebis Tam from Abu Dhabi as the vice president. And
Neeru sent it.
I asked for it as an introduction because Santosh withdrew is that I don't have any role. So we are, Ravi, we are addressing each other. So it's a closed meeting now. Yeah, please bring. Ready?
Thank you, sir. Thank you, sir.
Dear symposium chairs, dear colleagues, it's my great pleasure to be with you today and welcome to our ICO symposium. My thanks go to the All India Ophthalmological Society for their kind invitation to hold a symposium of the International Council of Ophthalmology. The ICO works with ophthalmology societies to enhance ophthalmic education and to improve access to the highest quality eye care. The first International Congress of Ophthalmologists was convened in 1857, and later in 1927 the ICO was founded. Soon we'll be celebrating its first 100 years of activities. The ICO is in official relations with the World Health Organization. And while the WHO works with ministries of health of their member states, the ICO brings ophthalmologic societies to jointly implement resolutions of the World Health Assembly and the recommendations of the World Report on Vision. The ICO work is guided by our strategic plan, and the focus is in 3 areas: ophthalmic education, advocacy for eye care and eye health, and support to our member societies. The ICO runs a number of programs supporting advocacy and ophthalmology society development, education, guidelines, and curricula. We run twice a year international examinations in ophthalmology in more than 80 countries around the world. Each year, the ICO gives a number of fellowship awards to colleagues from low-income and middle-income countries to study abroad and bring their new knowledge and skills back home. Our flagship program is the World Ophthalmology Congress. The next one will be held from 16 to 19 August this year in Vancouver, Canada. And I very much look forward to meeting you all there at our Congress. Again, thank you very much for joining us for our ICO symposium, and I wish you an inspiring and enjoyable time during the All India Ophthalmological Society annual meeting. Thank you.
Hello everyone. The next speaker is going to be Dr. S. Natarajan. Dr. Natarajan is the past president of All India Ophthalmological Society, on the executive committees and leadership positions of several other societies, both nationally and globally. and I believe he's also a member of the Executive Committee of International Council now. Dr. Natarajan is a very renowned retina specialist all over the world, and he's going to tell us about ophthalmic epidemiology and prevention of blindness, meeting global eye health needs.
Thank you, Nag, and thanks to Namrata for giving ICO a session here in All India Ophthalmic Society. I want to quote Helen Keller: the only thing worse than being blind is having sight but no vision. And we as ophthalmologists have to have vision for our own countries. And the objectives of discussion: to discuss the burden of global blindness, to discuss causes of blindness, to discuss strategy of blindness prevention. So here you see corneal blindness is 1%, the other is 6%, glaucoma is 6%, refractive errors is 20%, and we have cataract 62%, and posterior segment is about only 5%. So diabetic retinopathy is a preventable blindness, and I'm talking about the posterior segment diseases, and we have age-related macular degeneration, iridomacular degeneration, and others. Approximately, we have now, as of today, 100 million diabetics, with 58% do not know that they have diabetes. Globally, at least 2.2 billion people have vision impairment. Leading cause of vision impairment and blindness is refractive errors and cataract. Vision impairment poses global financial burden, with the annual global cost of productivity estimated to be US dollars 411 billion. And the burden estimates and the secular trend of blindness and vision loss, years lived with disability, global, regional, and national levels, age standardized the YLD rates, and estimated annual percentage changes, and the EPAC estimated annual percentage change ASIOIs due to blindness and vision loss decreased from 359.46 in 1990 to 327.98 in 2019 per 100,000 population. The global ASYRs per 100,000 increased from 94.26 in 90 to 95.81 in 2019. So the YLDs for blindness and vision loss were calculated by the prevalence multiplied by disability weights for the health state associated with blindness and vision loss. And the crude YLD rate due to blindness and vision loss at different age groups globally. And here females had higher ASYRs than males in 2019 in terms of blindness and vision loss. And this is a paper by S. Lee et al. And the global burden due to blindness and vision in 204 countries or territories, the ASYRs were the highest in Oman for moderate severe vision loss, followed by India. And the highest ASYRs were in South Sudan for blindness and in Nepal for presbyopia. In 2019, the ASYRs due to blindness and vision loss was highest in South Asia and lowest in high-income North America. And the epidemiology of vision morbidity in India, highest prevalence was seen in Bijnor, UP, whereas the lowest was seen in Thrissur, Kerala, thanks to the work by Praveen Vashist, who is with us right now. And this one is again the work by the Praveen Vashist, seeing the severe, moderate, and mild, and MSV1, which shows the prevalence and causes and types of blindness. We have, as I mentioned, cataract, uncorrected refractive error, glaucoma, posterior segment pathology, corneal blindness, and others. And types of blindness: economic blindness, social blindness, manifest blindness, and absolute blindness. The International Agency for the Prevention of Blindness, where our NAG was the president in the past, Global Alliance of Eye Health Organization for Blindness Prevention Activities. And in India, we have National Program for Control of Blindness, launched in the year 1976 with the goal to reduce the prevalence of blindness. And major activities under the program: primary, secondary, tertiary eye care services, and infrastructure development and capacity building, with apex at the aims with Dr. Praveen Vashist. And 2030 Insight, the future of global eye health, global strategy on WHO World Report on Vision, the Lancet, Global Health Commission on Global Eye Health, and the landmark UN resolution, Vision for Everyone. And this was actually in the UN raised by a Bangladeshi member. The objective is no one experiences unnecessary or preventable sight loss, and everyone can achieve their full potential. Eye care and rehabilitation services are accessible, inclusive, and affordable to everyone, everywhere, whenever they are needed. People understand the importance of caring for their own eye health and demand access to services free from the weight of any social stigma. and elevate vision as fundamental economic, social, and development issue, integrate eye health in wider healthcare systems, activate patient, consumer, and market change, and grant in aid for cataract operations in government sector and NGO private sector, reimbursement for cataract operation for NGOs and private practitioners per case, assistance for cataract operation for government sector per case, and also the NCBB is also giving now for diagnosis and treatment of diabetic retinopathy, ARMD, and retinal detachment. And the International Diabetic Federation estimates by 2030, 8.4% of India's adult population, 100 million, will have diabetes. But the Indian study by Madras Diabetic Research Center says already this year in 2024, we have 100 million diabetics. And prevalence of diabetic retinopathy in diabetics is 21.7%. They're published by the AOS in IGO. Lack of awareness of the disease, fairly long asymptomatic stage, visual impairment occur when diabetic macular edema or proliferative diabetic retinopathy sets in. And these are the various data report from diabetic retinopathy prevalence, work done by the AIOC group and in Maharashtra along with Dr. Gadkari in Pune. And these are the different models for screening. The Scotland has a 3 gatekeepers model. India has the Arvind model. Then Latin American and the Caribbean with a limited logistic and technical skill. And we have our own model in Mumbai and Maharashtra, screen, diagnose, and treat. We have a pre-camp awareness, assembly of diabetics, capturing of images and diagnosis by ophthalmologists, and same thing to be done in the state level, district level, and all over India. I don't have any financial interest. We use this mobile phone attached to the infrared device made by Remedio, can be mounted on a suitable bike for transporting for screening purpose, can be mounted on any table. Both mobile and the infrared device can be charged. And this is a comparison on a fundus on phone and size. And this is the one how it can be used by anybody. And I call this as a ABCD. Anybody can be used for screening for diabetic retinopathy. And most of the Indian, we have 1 billion smartphones in India with 1.4 billion population. They can use this, and the media software will tell whether the photograph has been taken well. And this can be used by anybody who's a literate or a illiterate. Only thing they have to handle the mobile phone, and the blue things is incorporated AI within the phone. And so the expected outcome, early detection and treatment after screening can reduce the prevalence of diabetic retinopathy even in the remote areas, reduction in the economic burden among poor and illiterate people, opportunity for a non-skilled worker to be trained as a semi-skilled worker for doing diabetic retinopathy screening. It will help to improve overall health of the population because we are also doing HbA1c, BP sugar for all the patients above the age of 40. And if they are diabetic, we do a free diabetic retinopathy screening. We also made a not-for-profit company to do this for the whole country, and the future plan is we are doing with the Mumbai Municipal Corporation. We have about 200 called a family health center. Now it's called Apla Davakhana in Marathi, and the same thing has been done by Shova Prasad in Kerala. It was a success where they used the AI and used 3 diagnoses. They had started in 16 family health centers with 4,000 patients, and later they expanded to 250 centers. They found 1 in 3 patients with diabetes, and this is what they did in the Kannur hospital. Similar model to introduce all over India, and this is a preliminary thing they did that. And this top blindness program, which I started in All India Ophthalmic Society, can be extended to all the NGOs, and hope that India can do that. And welcome you all to the International Council of Ophthalmology World Ophthalmology Congress to be held at Vancouver, August 16 to 19. Thank you. I think the next, thank you. Next we have speaker from Dr. Boris Malyugin. Can you introduce yourself?
Dr. Turin will be speaking on behalf of Dr. Malyugin. Dr. Malyugin is not here.
Whether COVID has done some impact on COVID pandemic has done impact on that diabetic blindness?
Whether diabetes increased, I think so. But see, during COVID, a lot of people developed diabetes. Is that your question?
No, I'm asking about diabetic retinopathy.
No, not due to COVID. No, COVID, because of the treatment, whatever was used, I think patient develops diabetes more, which has been published, but nothing to do with retinopathy.
Go ahead, please.
Okay. Dear Presidium, dear colleagues, let me present the report on the topic Epidemiology of Eye Disease in Russia based on the UEMS study. To provide eye care more efficiently, more data from large population-based studies are needed. That's why in UFA Russia Eye Institute, we conducted a cross-sectional populational-based study of people over 40 years to analyze the influence of various factors on the development of ophthalmic pathologies among the population of the Southern Urals. The Southern Urals is a large region in central Russia with typical demographic, natural, and national characteristics. About 6,000 people took part in this investigation. During the Ural Iron medical study, we assessed 683 different criteria, questionnaire and general somatic parameters, ophthalmological and laboratory parameters. During this study, the frequency of visual impairment was identified in accordance with the World Health Organization criteria. The degree of visual impairment was determined in the better eye. You can see this criterion on the slide. The rate of visual impairment in general was 6.4%. The rate of mild, severe visual impairment and blindness were 3.1, 3.1, and 0.19% respectively. Our analysis showed that the most significant causes of blindness and low vision are cataract, age-related macular degeneration, myopic degenerative maculopathy, diabetic retinopathy, and glaucoma. Our results are generally consistent with data from other epidemiologic studies. This slide clearly shows the difference in the frequency of these nosologies. There is a multiple predominance of cataracts among these factors. This slide shows the results of a multivariate regression analysis taking into account all factors in the population-based study database. Increase in the waist-hip ratio, tobacco smoking, cortical cataract, a longer axial length, high glucose level, and aging are the factors that significantly increase the risk of blindness and low vision. However, such factors as high level of education, high income level, and sunglasses wearing significantly reduce the risk of development of this condition. A typical social demographic portrait of a patient with blindness and low vision was formed. This condition is more typical for older age, widowed people and people living alone, having low education, performing a trade job with low monthly income, smokers, people suffering from obesity or conditions associated with impaired glucose tolerance. Cataract was diagnosed in 42.8% of respondents. Our study showed a significant predominance of pathology in women and in urban residents. The risk factors for development of cataracts are older age, female gender, living in the city, presence of diabetes mellitus, increased systolic blood pressure, shorter axial length. The prevalence of age-related macular degeneration is almost 14%. The incidence of early stage was 10.1%, intermediate stage 3%, late stage 0.7%. The proportion of each stage is presented in a pie chart. Our study showed a slight predominance of pathology in men rather than in women. These data are a big discordant with the global trend or in the prevalence of EMD in women. An interesting point is the significant predominance of pathology in rural residents. Our study showed a slight predominance. Our study showed a highest risk of any AMD stage associated with the following factors: older age, arterial hypertension, history of cancer and age-associated falls, history of glucocorticosteroid therapy, rural residence, shorter axis length, increased blood neutrophil level. An inverse association between AMD and diabetic retinopathy was revealed. Indeed, a number of researchers have noted the presence of diabetic or myopic retinopathy as factors counteracting the development of AMD. The prevalence of myopic maculopathy is 5.7%. The incidence of different stages is shown in this table. The proportion of each stage is presented in a pie chart. Degenerative maculopathy includes stage 2, 3, and 4 and accounts for 2.1% in the population. You can see the significant prevalence of myopic maculopathy in women and in urban residents. The risk of developing myopic degenerative retinopathy is high in people with lower axial length, taking glucocorticosteroids, suffering from cardiovascular disease including stroke, female gender, urban residents, older age, and a lighter iris color. We have to admit that the most of these factors relate to non-modifiable markers that cannot be influenced. The prevalence of glaucoma is 0.3%. The incidence of these stages is shown in this table. We assess stage according to the classification of optic disc change in glaucoma. The proportion of each stage is presented in a pie chart. But the most important point is the significant, more than two-fold, predominance of pathology in urban residents compared to rural residents in all stages of the disease. These data correspond to the global trend of the prevalence of glaucoma among urban residents. Our analysis showed the association of increasing number of glaucoma cases with the following factors: glucocorticosteroid therapy, older age, longer axial length, urban residence, increased systolic blood pressure, and high level of blood glucose. The presence of diabetic retinopathy was diagnosed in almost 2% of respondents. You can see the significant prevalence of this pathology in women and in rural residents. Among respondents with diabetes, the incidence of diabetic retinopathy was 17%. In the superpopulation with diabetic retinopathy, non-proliferative diabetic retinopathy was observed in 96% of individuals. The proliferative form was diagnosed in 4% and diabetic macular edema in 12%. The analysis showed an association with older age, high serum glucose concentration, history of insulin therapy, high systolic blood pressure, longer history of diabetes. Overall, this study showed that age, changes in the length of the eyeball, diabetes, or increased blood glucose level were the most frequent factors associated with these ocular pathologies and perhaps the causes of their development. Benefits of the UMS study are early detection of these socially significant eye diseases and strengthening the prevalence component of health care by reducing the risk factors for the development of these socially significant eye pathology. In addition, scientists from UFA Research Institute, in collaboration with universities and research institutes in Europe, Asia, and America, have published more than 100 scientific papers in leading international journals. We will be very glad to see you at the East-West Conference in Ufa, Russia in summer. Thank you.
Thank you. Can I invite Boris to come and sit here? Boris, you can come and sit with us. Anybody has any comments or questions? Ravi or Praveen? Come, Boris, join us. You can use the microphone. Thank you for it.
Actually, this is the first time I am listening to any presentation from Russia. Happy to know that the prevalence of blindness and visual impairment is very low in Russia. Something odd which you find in India, usually the problems are higher in rural population, but in Russia it is much more in urban population. This is one different I could see. Thank you.
Thank you.
So
Yes.
we can move on. So
Okay.
I think this is the major epidemiological study in Russia. So we don't have any other more precise and more fresh data on the epidemiology. And I believe it was published in major journals, including Nature, and it is most comprehensive so far. So I think we can rely on these numbers until the next study. Thank you.
Thank you, Boris. So next we have Dr. Gulapalli Rao to speak on Post-Vision 2020, current challenges. And he's the Chairman Emeritus of LV Prasad. He created an international ophthalmic hospital in the entire Telangana and Andhra. And also the past president of International Association of Prevention of Blindness and Academy of Ophthalmology Internalis. Thank you, Nag.
Thank you, Nati. What I'd like to share with you in the next 8 minutes is a broad overview of the future challenges and what perhaps we can do about them. These have been shown repeatedly by many people, and I don't have to go into the details of this magnitude of problem around the world. But one thing that comes out of all these studies is the prevalence of visual impairment is decreasing worldwide. Although because of the aging population, as well as other problems, the absolute numbers seem to be going up. There is a significant demographic shift for population over age 50, and eye care in many parts of the world is still not an integral part of the health policies. The end of infectious causes of blindness appears feasible. Some of the successes we have had with onchocerciasis, trachoma, etc. We're also seeing the rise in chronic eye diseases that require more complex systemic development approaches and campaign approaches. One positive development is the significant technological advancements that are helping us to provide better coverage and become more precise in our quality parameters. Another neglected area continues to be the vision rehabilitation programs for people with irreversible form of vision loss. India is supposedly still has about 8 million people or so blind, about 5 times that number with serious vision impairment. These are all the common causes that is contributing. The risk factors include more common among women, lower socioeconomic groups, those who live in rural and remote areas, and a significant geographic disparity. If you want to see a nation in which no one is needlessly blind, and where those with unavoidable vision loss can achieve their full potential, we have to switch gears a little bit. And can we close the gap by 2030, 2035, 2040? What do we have to do? We have to, I believe, approach eye care in a comprehensive way, to promote comprehensive delivery models. Cataract problem, the residual problem that we have, and the increasing number of cataract surgical requirement also has to be tackled more aggressively. Uncorrected refractive errors is still elusive. It appears simple, but we haven't made a big dent in tackling this problem. In our country and in South Asia and sub-Saharan Africa, corneal blindness is a major cause. Retina, glaucoma, and childhood blindness fall within the realm of more complex problems and require highly trained human resources, infrastructure, and follow-up mechanisms. So when you look at education, technology, research, and advocacy, We have to advocate for a comprehensive delivery model that is appropriate, that's available to all people, affordable and accessible. And we also have to see how we can migrate as much care as possible to the bottom of the pyramid, to the primary and secondary levels. Some of our studies at our institute clearly indicated if you have an integrated model of secondary and primary care in the rural areas, 80 to 85% of those patients don't have to travel to any cities and towns. Adding to benefits of cost, comfort, and today's world carbon print. All eye diseases have to be looked at. We no longer can neglect some diseases. It has to be at multiple levels of care and appropriate to that level of care. Cataract surgery today in our country, while we have a very good record of over 8 million cataract surgeries performed during the past year, our need seems to be somewhere near 14 to 15 million if you include everybody that wants the cataract done. What we have to work towards is to involve a higher percentage of our ophthalmologists in performing cataract surgery. Let us imagine even half our ophthalmologists, 15,000 of them perform 5 surgeries a day, 200 days in a year, we reach the 15 million. How do you do that is the challenge that we have to face and address. Progress in cataract surgery has become possible in India because of multiple factors. Serious governmental commitment for the past nearly 4 decades or 5 decades. We have better systems now, better models, greater accessibility, and availability of indigenously manufactured consumables and equipment, saving costs substantially and making us perhaps the least expensive eye care delivery model in the world. It's the most common surgical procedure, economic incentive to professionals, an immense professional satisfaction, comfort level, less hassles, and of course the governmental commitment. Public is also significantly aware of the cataract problem. In education, progress has been made in the area of subspecialty fellowships, short-term fellowships to enhance competencies of practicing ophthalmologists. The residency remains a challenge, the quality of residency training in our country, and we have to tackle it head-on instead of wishing it away. Short courses, training of trainers is very important. Funding comes from out-of-pocket, government, philanthropy, cross-subsidization, insurance, and international grants. And we need to have more commitment from all sectors to tackle the problem. Quality, can we also become better doctors beyond cataract surgeons? For uncorrected refractive error, the estimate is 20,000 to 30,000 vision centers are equivalent or required in the country. And a promotion of indigenous optical industry the way we have done in the area of other surgical consumables. And corneal blindness, we need 50 high-quality eye banks, 500 major hospitals with hospital cornea retrieval programs, and cornea service in every medical college and every tertiary hospital in the country if we were to ever reach the target of 100,000 corneal transplants a year. And in other subspecialties of retina, glaucoma, etc., we have to create more ophthalmologists committing to these subspecialties and practicing them. So comprehensive care, secondary and primary levels, is also to be looked at. In subspecialties in medical colleges to provide better care, better access, and better education to the future generation of ophthalmologists. Link district hospitals to medical colleges, PH2s to district hospitals, more programs for education, better quality, innovative techniques. And another important parameter is embracing technology to enhance care and research and to enhance education. For research, we may have to look at the possibility of creating a national eye research fund, promote active eye research centers, bring in culture of research in our medical colleges. Advocacy, we should continue. We have been very successful until date with central and state governments, foundations, and philanthropies. So ultimately, we have to look for that combination of the 3 T's: the talent that can use technology more effectively, and never lose sight of the fact we are in healthcare. The tenderness to deal with individuals is very critical. Emerging challenges are elderly care, newborn, myopia, the very vulnerable populations living in the remote rural areas and tribal areas. Ladies and gentlemen, for success in medicine, there are 3 core requirements, as said by Atul Gawande in his book, Better: diligence, to do right, and ingenuity. And no more is it more required than in dealing with our problem of vision impairment in our country. Thank you.
Thank you, Nag. Boris, you have any comments?
I think you have in India a very good strategic plan of how to eliminate your blindness, and I wish we have the same in Russia, because I never have seen such a strategic planning on that. Maybe because you have much more cataracts than we, and so you're facing a lot more infections than we are, so probably you have to be more proactive in that regard, and I believe that's kind of a difference. Although our government is also working hard to do the same things, but it looks like you started a bit earlier, and then you are in more advanced stage so far. Yeah.
Thank you, Boris. Anybody wants to ask anything?
One
Yes.
comment. You're right, Boris. We have been fortunate in India to have some visionary leaders in eye care over the past 3-4 generations. And they created a culture of philanthropy among ophthalmologists of India. So we can be very proud that I'll constantly fight with our other medical colleagues and tell them point blank, we are the most philanthropic specialty of all medical specialties. And I challenge them to prove me wrong. Because I think it started in the 60s and 70s, and it continues. And the involvement with the government, the public-private partnerships, all this certainly contributed.
Okay.
Thank you. So, anybody has any questions or comments? Okay, if not, request Dr. Ravindran, Chairman of Arvind Group of Eye Hospitals, to speak on prevalence of cataract in Indian population and strategies for management. And all of us know Arvind is doing a leading role of prevention of blindness and needless blindness, started by Dr. V. And so happened Ravi and me are same batchmates.
Thanks, Dr. Natarajan, for the opportunity to speak in this session. So I'm going to talk about the prevalence of cataract and what are the management strategies we should have in the Indian population. I mean, there was a paper way back in 2008 where Dr. Murthy and et al. And also Dr. Praveen had projected that among the people aged 50 plus years, the cataract surgery would double from 3.38 million to about 7.63 million in 2020. And that is what actually happened. Last year, we have done close to about 8 million surgeries, more than what they predicted. But as you can see, that CSR among that age group has not become doubled. It has only marginally increased because the number of people in that population also had considerably increased. So even this doubling doesn't really help. So, but this increase in the volume of cataract surgery that happened over the last 2 decades has really helped to bring down the prevalence of the cataract blindness in the community. And all this work that had been done by the as Dr. Rao rightly pointed out, by the several philanthropic organizations as a specialty, we were able to bring down the presenting visual acuity of 6/18 or less, which indicates moderate, severe visual impairment along with the blindness from 5.3% to about 2.55%. And again, the people who are blind from 0.68 to about 0.36%. So this has been a significant achievement. And this is the data we have from the 2019 RAP survey. The overall blindness is about 0.36, whereas the moderate visual impairment along with the blindness is about 2.55%, and the early visual impairment, which we are focusing now, is close to about 3%. So there is a large amount of work, nearly close to about 5.5% of the population needs some care. And that translates, if you look at the numbers, it's about 34 million people who have moderate, severe visual impairment along with the blindness, and about 38 million have got early visual impairment. That's a group. So there's a large amount of work, almost close to about 75 million people who need care. And if you look at the presenting visual acuity of less than 6/18 or the moderate visual impairment or worse, the major contributing factor is still the cataract, which is about 71%. And again, if you look at the distribution of the blindness in the 50-plus population from the survey, contrary to what we saw in the Russian study, here the rural prevalence is much higher compared to the urban. And again, the people who are uneducated, the prevalence of blindness is way high, at least about 8 to 9 times higher compared to the people who are educated. Which means, we also need to create access and make it affordable for the population. I'm just sharing the data from Aravind. Last year, we had done about 447,000 cataract surgeries. As you can see, nearly 60% of the patients have used the free walk-in services or the services through the camp. So which means, we have to really have way of making it affordable to accessible to the population. Here again, the survey brought out nearly 40% of the patients got operated in the government sector. Maybe between the NGO and private, probably equal number. Maybe 30% would have been operated by the NGOs and 30% would have been operated by the private. So which means nearly about 70% of the patients still look at accessible and affordable services, which means we need to ensure the access for them either through the vision center or through the screening eye camps. It becomes very, very important. That I look at as strategy number one. So that's most important, that we create this access. The other area we have to really look at is the gender. Here I just want to share this data. If you see here, the number of women who got operated in our hospital last year is about 56%. If you look at it is almost like 33% higher than the surgeries done in men. But if you look at the prevalence of blindness, it's almost 38% higher among the women. So being a woman itself, is a huge risk factor, which also came out in the presentation by Dr. Rao. So whether it is 2001 or 2007 or 2019, all the surveys have showed among the gender, women have got a much higher prevalence of blindness, even though it has considerably reduced over a period of time. And again, if you look at this data, here I'm projecting the surgical data of the patients who underwent cataract surgery. If you look at the age group of 41 to 50, for every 1,000 men we have operated 1,800 women. Okay, and between 50 and 60, it's about 1,500, about close to 1,600 women got operated, but that comes down. Only the 70-plus age group, the number of surgeries done in women is less, or the number of surgeries done in men is much higher. So not only the number of surgeries in women is higher, but the onset is also much earlier for these people. So and the majority, the way we also have to look at it is still the prevalence is much higher, and many of these women are also in the productive age group, where they really need a good vision to take care of them and the family. So I think how do we increase the number of surgeries in women is very important. I mean, this, whatever the data I'm showing, it also has come out from several global-based study, and there are no evidence to show that it's related to the lifestyle, but it all has been related, it has been related to the estrogen, and it is hypothesized that, not strictly the concentration of the estrogen, but more as a withdrawal effect. So as the menopause sets in, the incidence of cataract also becomes much higher in women. But what we have seen is there are also trials that have done hormone replacement therapy. Trials have also not shown any conclusive evidence to show that replacing them with some hormonal therapy is going to help. So we are still yet to find out what really causes this. And what we can do is how much more we need to operate. Among women, we did a study in Theni to understand the eye care needs of the population. Here I just want you to look at the CSR. Based on this population, we found the CSR among the men is around 7,900, or it's close to about 8,000. Okay, the women, it is already higher at 10,000. So, okay, so, and overall it's about 9,000. This is one of the very well-served community, and we feel, but majority of the districts across the country, maybe half of this number, maybe like 4,000 to 5,000. It's already the highest things are happening. But even in this population, if you look at the visually significant cataract, it's about 12.2% of the people in the age group of 40 or above in men. Men is about 12.2%, whereas it is in the females, it's about 13.6%. It is already it's about 10 to 12% higher in the women, which means, in spite of operating higher CSR among the women, which is almost like, 8,000 in men, here it's about 10,000. Still, there are much more women who need cataract surgery, which means, we also looked at how much more. Today we are doing about 1.3, or maybe like the CSR ratio for between female and male is about 1.3. This has to become probably about 1.5, which means probably if you have to, let's say, we have to take the whole cataract surgical rate, maybe like 15,000, 5,000 maybe have to be men, and 10,000 probably have to happen in the women. So. And while the current strategy is to increase the number of surgeries, that alone probably may not help. This we also need to look at other causes. How are we going to look at the ways how we are going to delay the onset of cataract? Is it possible to prevent the occurrence, or is there a way to slow down its progression? Something we need to explore. One is, they say smoking. If you are able to bring down the smoking, and if you are able to give some kind of protection to ultraviolet, probably we'll be able to slow down. And we also did a study along with All India Institute about almost like 15 years back. And what came out there is, beyond the age and the gender, what we found is the level of the antioxidant. There was a strong association between the level of the antioxidant. That's an inverse association between the antioxidant and the cataract. And while we also saw that with the lutein, zeaxanthin, retinol, the very strong inverse association is what we found with the vitamin C. And now if you have people with a quartile, with the group of people who had a much higher concentration of vitamin C in the plasma, had the lowest prevalence of the cataract. So which means, is there a way we can provide much more balanced diet, food which is rich in the antioxidants? Probably it may not be possible today that can be done by any of the philanthropic organization, by the government, but it is only the socio-economic development of the whole country probably will address this. Probably the answer is not with this or with the government. So to conclude, I think we have made a lot of progress in the control of cataract blindness, but what we need to make sure is we have to ensure access and affordability of the cataract services. We need to develop physical and human resource infrastructure of primary eye care. We also overall have to increase the cataract surgical coverage. From today, it's about 6,000 to 7,000 to about 15,000, as Dr. Rao mentioned, and again with a special focus on the women, and also promote better dietary habits to slow down the cataract onset. Thank you.
Thank you, Ravi. Nag, you want to comment something?
think it was a comprehensive coverage of the problem of cataract, the past, the present, and the future. And I think it is very well covered.
It's a fantastic presentation, sir. Really nice. Issue is that, yeah, of course, cataract prevalence overall is reducing, but still we are doing more surgeries. One important question, why it is higher in women? I think the most important factor is that life expectancy in women is higher. Since cataract is age-related disease, that's why it's much higher in women, sir. And nowadays, even what we see that sun exposure, it is also important risk factor. We have done ICMR study on this thing, and probably it is one reason that cataract is not reducing. As far as number of cataract surgeries conducted in India, sir, we gave a figure of 2.70 crore surgeries to be done in 3 years. But this number is based on number of blind and visually impaired due to cataract. If we are doing a surgery in a patient with visual acuity in one eye is 6/36, otherwise better than 6/18, that is not part of that. And unfortunately in India, most of the surgeries are being done on those patients only. We have an example of Gujarat, even there the cataract surgical rate is more than 16,000 per million. Still it is not eliminated in Gujarat. So you can understand, until and unless we'll give priority to blind and visually impaired, it is not possible to eliminate cataract blindness.
As Dr. Praveen said, I also used to think it's all related to the longevity of the women, but the data we have doesn't show that. Because at the age of 70 plus, the cataract surgery among men is more. And the Teni survey we did, we also found the visually significant cataract to be more among men above 70 years. It is lesser. As they become older, the prevalence of cataract also becomes lower in the women. So it all seems to be much earlier onset. So what our conception that because women live longer, there are more women in the population, we have cataract may not hold good from this data.
Another factor we noticed related to that is the percentage of women seeking cataract surgery is far higher in our secondary centers. That means when you take the care closer to them, they access it. If you expect them to travel a distance, women usually don't. So that's a factor too, looks like.
In your presentation also you mentioned one of the risk factors is women. And in what angle is that? Same, okay.
The percentage of women with cataract blindness is higher than in men.
We also looked at, because I saw this data, I looked at all the other diseases except diabetic retinopathy, all other diseases, whether it's cornea, glaucoma, orbital, lacrimal sac, everything women is higher than men. I'm not sure what is the reason for that.
Maybe the women empowerment to go to the hospital.
Among paid surgery, what is the distribution between male and female?
So among the paid patients, there are far greater men get operated than the women. As he said, the women go to the free hospital and also more to the camp. But the men, I showed you that 43% men got operated, but if you take the paying patient alone, it's 50% men. But if the free side, it is 40% or less men and 60% or more is women.
Thank you, Ravi, for a wonderful presentation and discussion. Now I invite Dr. Praveen Vashisht, heads the community ophthalmology in AIMS and doing a lot of work for sitting in the Apex Center to the whole country.
Thank you, Natajan, sir. In fact, it is my privilege that at this stage, I am sharing this stage with probably the most well-known ophthalmologist in the country. Thank you, sir, for inviting me. In fact, today I would like to give you some initiative that has been taken by Government of India for elimination of trachoma in India. Trachoma is still, mainly in African countries, is considered the most common cause of infectious blindness. WHO started a global elimination trachoma program in 2000, and now that they will eliminate trachoma by the year 2020. But unfortunately, among CRO country, India is the only country where WHO has not yet declared trachoma elimination. We have a huge history. In fact, in 1959, it was first time ICMR survey was conducted, and where we came to know that the burden of trachoma is very high in northwest part of the country. In fact, this is the status. In Punjab, Haryana, you can see the prevalence of active disease in 1950s was more than 50%. And at that time, the name of the national program in 1960, it is National Trachoma Control Program. It was not NPCB, it was National Trachoma Control Program. In fact, in 2006-07 also, the burden was reduced significantly. But this is one success story of Andaman Nicobar. I became head of department and I was invited by Government of India to see the burden. And surprisingly, when we visited there in Nicobar Island, we found that 51% children, they had active disease, 51%. And it was one of the important cause of blindness there. It was probably the first time mass treatment was given with azithromycin for consecutive 3 years in the entire island of Nicobar. And fortunately, we got the huge reduction of trachoma in that area. In 2013 and 16, when we conducted survey, the prevalence of active disease was nearly 1%. From 51%, we reduced it to nearly 1%. And then it was planned whether to assess actual burden of trachoma. We got this National Trachoma Survey from 2014 to 2017. Again, it was funded by NPCB. And it was conducted in 27 different districts in the country. 10 districts where trachoma was hyperendemic, so we did prevalence survey there. And in another 17 districts, we have taken randomly one district from each state by rapid assessment to actually assess whether trachoma is there in rest of the country or not. As per finding of this survey, we were happy that the burden of active disease in children from 1 to 9 years of age, it was reduced to just 0.7% in the country. 0.7%. WHO cutoff for elimination is 5%. So you can understand, we were proving it in 2017. If somebody could have done this kind of survey way back in 2000 or maybe 90s, probably would have declared trachoma in children at least free at that time also. 0.7 is such a low figure. And in fact, at that time, our ministry, health ministry, they declared that at least children, they are free of the burden of trachoma is not a public health problem. But what about trachomatous trachiasis? It is actually, trachiasis is commonly seen in 15 plus age group as a complication of trachoma, active trachoma. What we got is the prevalence of 3.5 per 1,000 in 15 plus age group, trachomatous trachiasis. And the cutoff criteria for WHO for eliminating trachomatous trachiasis is less than 2 per 1,000. So we could not declare that India is totally free of trachoma. But we actually finally called a WHO team, which was led by Dr. Solomon, who is even now the program officer for trachoma in London School and WHO. And we discussed whether we can declare India free of trachoma. But he said, no, you can't declare. In fact, he said you have to conduct survey in all the previously hyper-endemic districts in the country. And when we assessed, that number was nearly 200 districts. They said trachomatous trachiasis survey has to be conducted in all 200 previously endemic districts. And if the prevalence satisfies the WHO criteria, only then India can declare trachoma free. And he also said that we have to show that the safe strategy for trachoma has been implemented in all those parts of the country. So as part of the ministry, decision was taken that we'll do this thing. In fact, all training were given at national level, state level, district level, and PSC level. Modules were developed. The people were trained. IEC material were developed. That means in all those 200 districts, which were spread in 11 states in the country, the trachoma safe initiative were implemented. And in fact, surveillance report, all the districts are supposed to submit surveillance report if any case of active disease or trachomatous trachiasis has been identified. And then, as I mentioned, that 200 districts to be covered with this survey, this work was given to RP Center. I was made principal investigator. And this is the list of those 200. This is the distribution. You can see that this is the northwest part of the country. And these are the 200 districts, state-wise. one important thing which was given by WHO is that if a TT case is known to health system, then it will not be included in prevalence. So somebody who has been operated and recurrence is there, or somebody who is known to health system where tracheasis has been removed, that will not be included in prevalence. So in fact, we assess the prevalence of tracheostomy, and in fact, WHO Tropical Data Group was our partner for this survey. They did training to trainers in our RP center, and we further train our team members. 3,000 was the sample size in each district, so you can understand we had to cover at least 600,000 people by house-to-house visit in 15+ age group. And of course, from each enumeration unit in the district, they took 30 clusters, and from each clusters, 35 households were covered. We mainly examined for tracheatic lashes, eyelashes, and also for upper lid scarring on those individuals. Of course, quality assurance was an important component. All the data was entered in Tropical Data software. It was online data entry in mobile phones. And regular checkup. Daily data cleaning was maintained, and we are submitting data daily to Tropical Data team. I'm happy to share that we have just completed the survey in 200 districts. We have enumerated 730,000 population. I believe this is the largest ever survey globally. Nobody has gone to such population and community. The coverage was 88.4%, 645,000 people were examined. The TT cases who were unknown to health system, total number of cases identified were 162. Again, the just prevalence was just 0.25 per thousand. You can understand the cutoff was 2 per thousand. We got 0.25 thousand. And in all the state, the prevalence was less than the WHO criteria. This is summary table. This is all details about enumerated population, each state, examined, TT unknown to health system, and also we look for corneal opacity due to trachoma and blindness due to trachoma. The prevalence of all these things is extremely low. So just 0.25 per thousand is the prevalence against WHO cutoff 2 per thousand. So we can understand that trachoma is definitely eliminated in our country. It is no more a public health problem, but we have a process. Now, the government of India has kept a task force. I'm member secretary of that task force. The meeting is kept on 22nd of this month. In that task force, we'll be finalizing a dossier, which will be submitted to WHO. And based on that dossier, WHO is expected to actually declare that India is free of trachoma. And it is planned that by this year, probably by the end of September or October, hopefully we'll get declaration that India is free of trachoma. Thank you very much. I'm really thankful to Government of India, WHO, Tropical Data teams, Chief RP centers, and all the partners, district, states, who help us in this survey. Thank you very much. Thank you.
Thank you, Praveen, for your passionate work you're doing from All India Institute. Nag, you want to say something? Boris? Yeah.
So actually, I think in Russia at that time it was Soviet Union. The trachoma was eliminated in about 1960s or 70s. So it was kind of again government program, which we can see here as well. So because without government support, it's not possible, because you have to go to the rural areas and treat all these people, and that's. But I believe you are at the final stage of that story. So it's congratulations to all your hard work in that area. Yeah.
I just want to congratulate you for completing such a mammoth task and finally getting it all done. Because in 1970-74, when I was a resident in RP Center, every alternate patient used to have some signs of trachoma. And from that stage to this stage was an uphill travel. And then the other thing that in the late 90s and the first decade of 2000s, when I was frequently going to Geneva, They were constantly asking me, Nag, ask your government to get it done and get a trachoma-free country status for India. And I used to tell them, we don't see trachoma. They said, no, that doesn't serve the purpose. There is a system. And I'm glad that it's all done now, and we are a trachoma-free country.
Thank you. Ravi, any comments?
I just have one doubt, Praveen. Every now and then I think we have these tribal, remote, vulnerable populations. Occasionally I get a doubt, even in our states, do these people have trachoma? So I don't know if you've looked at some of those.
In fact, one of the important component is surveillance in each and every district and monthly report. And the process was that from PSC level, it will go to CHC, CS to district level, and district will report to state and to center. And we are submitting annual report to WHO. So that was part of the process, surveillance, along with this survey. So we hope that it is not there.
But as he said, we can also probably contact, apart from this, what we have done excellent, whether we can contact the tribal community all over India.
I would like to mention one thing, sir. You know, the prevalence of active disease is like the WHO taken a big figure. So less than 5% is taken as elimination criteria. So even tribal area, if we find some cases, the prevalence, they will definitely be less than 5%, hopefully, sir.
Sure. No, I know, but just to serve them, because we have so much of tribal, and our Prime Minister also was talking about tribal welfare, and during the GE meeting also he did that. Good. But anyway, wonderful work you are doing, and applause to you. Can I request the speakers to come here? We can have a group photograph. In the meantime, any other question? Any other comments from our colleagues from Russia? Okay. If not, thank Dr. Namrata Sharma, the scientific chair, for giving us the opportunity from ICO to discuss this in India. Thanks to Boris for accepting in the last minute. Thanks for... can you have the group picture? Amol, can you take?